So let's review fat and lipid metabolism, some clinical MCQs in this, and this will be the first MCQ for this series of lectures on fat metabolism. The first question says, what is the most positive activator of the process shown below? So this is the process of fatty acid synthesis. So we're trying to synthesize palmitic acid, and one major enzyme that we need in this pathway is called acetyl-CoA carboxylase. And one of the factors that actually help make this enzyme active is citrate. So when citrate level in the cytoplasm begins to increase, it causes the polymerization of dimers of acetyl-CoA carboxylase enzyme. And once they polymerize within the cytosol, it converts acetyl-CoA into malonyl-CoA. So citrate is one of the most important activator, positive activator of this process. So the answer to number one would be citrate. So when adipose tissue stores triglycerides arriving from the liver or intestine, glycolysis must also occur in the adipocyte. Which of the following products of intermediate of glycolysis is required for fasted? We actually checked it in the lecture, where we said that insulin will cause the glucose to be bind to its receptors on the adipose tissue, and glucose will go through glycolysis, and one glycolytic intermediate, which is called DHAP, needs to be converted to glycerol 3-phosphate, and the enzyme that does this glycerol 3-phosphate dehydrogenase. So the answer to this is DHAP, option E. So question 3 and 4. A-beta lipoproteinemia is a genetic disorder characterized by malabsorption of dietary lipid, steatorrhea, accumulation of intestinal triglycerides, and hypolipoproteinemia. A deficiency in the production of which of the apoprotein will likely account for? We said is apoprotein B48. It prevents the formation of chylomicron, so that's why there will be hypolipoproteinemia. So if ApoB48 is deficient, we're going to have that condition. Patients with A-beta lipoproteinemia exhibit membrane abnormalities in their erythrocyte, which with production of acanthocytes, that's tawny appearing cells. This unusual red cell morphology will most likely result from malabsorption of what? Now, during the build-up of chylomicrons, what happens is that some essential lipids are also part of that build-up. So if this patient cannot form chylomicron, the patient will also have deficiency of essential lipids, and out of the options here, the only essential lipids is linolenic or linoleic acid, also linolenic acid, and other essential lipids we have are vitamin A, D, E, and K. So any essential lipid, the 6 of them, can be deficient in patients with A-beta lipoproteinemia. So the answer to this is also E. A patient with a history of recurring attacks of pancreatitis, eruptive xanthomas, and increased plasma triglyceride levels of greater than 2,000 milligrams per DL associated with chylomicron most likely has a deficiency of what? The answer is lipoprotein lipase. If lipoprotein lipase is deficient in a patient, chylomicrons cannot be broken down and there will be excess in the bloodstream. So this condition is also called familial chylomicronemia syndrome, FCS, and it could also be due to a deficiency of ApoC2 in some cases. So an individual containing an inactivating mutation in a particular muscle protein, which leads to weight loss due to unregulated muscle fatty acid oxidation. Such an inactivating protein could be which of the following? The answer is actually acetyl carboxylase. The answer is E. Option E is the inactivating mutated protein, because if this protein is mutated, malonyl-CoA cannot be formed, and malonyl-CoA is what is responsible to help us to synthesize fatty acids. And also, malonyl-CoA actually helps to inhibit fatty acid beta oxidation. So if malonyl-CoA is not also present, we'll have fatty acid beta oxidation not inhibited, and it will be overworking, and the patient will still become lean. So that's exactly what happens here. Question 7. A mouse model has been generated as an in vivo system for studying fatty acid synthesis, and an inactivating mutation was created which led to a cessation of fatty acid synthesis and death of the mice. The mutation is most likely in which of the following proteins? Now, if we have citrate translocase mutation, citrate cannot leave the mitochondria into the cytoplasm, so it needs to leave the mitochondria and come into the cytoplasm, where citrate gets converted to acetyl-CoA and oxaloacetate by the enzyme the citrate lyase. So it needs a translocase to leave the mitochondria and come into the cytoplasm. So if this translocase is mutated, we're going to have deaths because the mice cannot synthesize fatty acid. So that's the answer here. Question 8. An individual with a biotinidase deficiency was shown to produce fatty acid at a greatly reduced rate in the absence of supplements as compared to someone who did not have deficiency. This is due to which of the following? There is what? There's reduced ability to form malonyl-CoA because this enzyme, biotin is needed by this enzyme acetyl-CoA carboxylase. Acetyl-CoA carboxylase needs ATP, needs biotin, and needs CO2. It's an ABC enzyme. So if biotin is absent, the patient cannot form malonyl-CoA, and we have already said that this enzyme helps acetyl-CoA to become malonyl-CoA. So there's reduced ability to form malonyl-CoA. So that will be the answer, option E. Question 9. Liver fatty acid oxidation leads to an enhancement of gluconeogenesis via which of the following? It actually activates pyruvate carboxylase. What happens is that during fatty acid oxidation, a lot of acetyl-CoA is produced inside of the mitochondria, and acetyl-CoA is an obligate activator of this enzyme pyruvate carboxylase, which converts pyruvate into oxaloacetate. So if fatty acid is enhanced, then gluconeogenesis will actually be enhanced too, because acetyl-CoA would stimulate this enzyme to produce glucose via the process of gluconeogenesis. Also, activation of this is most likely correct. Question 10. A knockout mouse was created in which the ability to create conjugated bile salt was greatly impaired. So bile salts are not being created. The net result of this mutation in a mouse fed a normal diet is which of the following? The mouse will have steatorrhea because bile salts are not present. So the process of emulsifying the fatty diet is actually lost. So this is steatorrhea due to exclusion of bile. Question 10. You see a patient who has steatorrhea with very low levels of chylomicrons and VLDLs in his circulation. Circulating triglyceride levels are extremely low. Examination of intestinal epithelial cells shows lipid-laden cells. A possible enzymatic defect leading to these findings is which of the following? Now, when VLDL or chylomicrons are affected, it means there's something wrong in building these lipoproteins. And we said before that ApoB needs a particular protein called microsomal triglyceride transfer proteins to build this lipoprotein. So if MTTP is absent, both VLDL and chylomicrons would be affected automatically. So option C is the correct answer. Question 12. A type 1 diabetic who has neglected to take his insulin for a few days displays both hyperglycemia and hypertriglyceridemia. The hypertriglyceridemia is due to which part? There is reduced secretion of LPL. Insulin upregulates LPL in adipose tissue. So if LPL is not upregulated, triglycerides cannot be broken down in the blood from chylomicron. So there will be excess chylomicron in the bloodstream. So that excess chylomicron in the bloodstream is because insulin was not present to activate or upregulate the secretion of lipoprotein lipase. Question 13. A 12-year-old female presented with severe abdominal pain and was found to have a markedly elevated plasma triglyceride concentration of 750 milligrams per DL. A A lipoprotein analysis revealed elevated levels of chylomicrons and VLDLs and reduced levels of HDL. Which protein might be defective in these patients? The answer is ApoC2. ApoC2 is deficient in these patients. We are going to have triglycerides build up as chylomicrons, and also ApoC2 is needed to break down to activate the lipoprotein lipase, which breaks down the triglyceride present in chylomicrons and also in VLDLs. A 43-year-old woman presents with steatorrhea. Fecal analysis reveals the presence of elevated triglycerides, phospholipids, and cholesterol esters. Levels of carbohydrates and proteins were normal. The physical examination is unremarkable. Possible defects in the release of which of the following will lead to the result? The answer is secretin. The woman has normal digestion of carbohydrates and proteins, which means pancreatic enzymes were released, so CCK is not a problem. The problem is that secretin was not coming out to actually buffer the chyme. The chyme was acidic, and secretin needs to buffer the chyme to make the bile salt have the emulsification functionality. So if chyme was not buffered by the bicarbonate coming from the pancreas, bile will not function well and fats cannot be digested. That's why she has steatorrhea. So the answer to this is secretin. Question 15. A 6-year-old child presented with complaints of anxiety and easy fatigability, abdominal pain after ingestion of fatty meal. A physical examination showed that the patient had eruptive xanthomas on the arm with signs of hepatomegaly elicited. Lipid profile. This is all telling us a telltale signs of she has familial chylomicronemia syndrome. So that's the answer here. You could go back to the lecture notes and review familial chylomicronemia syndrome. And this is the milky blood that we talked about. So this is the milky blood, which is a blood that has a lot of fats present within the plasma. So this ends the series of this MCQ review. Thank you guys.